It's 8th of March today, and today we celebrate every woman on the planet. Women bring so much love and beauty into our world by just being in it, and it makes everyone a little bit happier. The sun shines brighter when you smile. So, ladies, keep smiling. Good afternoon, everyone, and happy Women's Day. Also, thank you everyone for finding time to join the webinar. Breast Cancer Awareness. Breast cancer is a cancer that forms in the cells of the breast. After skin cancer, breast cancer is the most common cancer diagnosed in the women in the United States. Breast cancer can occur in both men and women, but it's far more common in the women. So today, Dr. Manjula Rao will brief us about the same. Moving on, let me brief you with the organization first. DigiSaksham. DigiSaksham is an initiative by SEMS Group, which has developed content over 300 courses in multiple languages, which ranges from 4 hours to 6 months in various sectors of IT, BFSI, retail, and entrepreneurship for all age groups from school children, youth, professionals, and senior citizens. DigiSaksham has also conducted more than 100 webinars, 10 FTPs, workshops, and 6 international conferences. DigiSaksham impacted more than 15,000 lives to various webinars, conferences, workshops, and seminars across the globe. Let me also introduce you all to the speaker for today, Dr. Manjula Rao. Dr. Manjula Rao is a consultant, breast specialist, and oncoplastic surgeon at Apollo Proton Cancer Center, Chennai. Without further ado, let me hand over the mic to Dr. Manjula Rao. Please, ma'am.
Thank you so much, Anshika. Thank you. Thank you for having me, inviting me today to give you all this talk. Heartfelt gratitude to SEMS Welfare Foundation and DigiSaksham as well. Let me just introduce myself. I am Anjali Rao. I'm a breast oncoplastic surgeon. I'm a breast cancer surgeon. I practice at Apollo Proton Cancer Center, which is one of India's premier cancer centers and the only center in the whole of Southeast Asia to house a proton radiation machine. We are based out of Chennai. Before Apollo Proton Cancer Center, I was practicing as a consultant at one of India's oldest cancer centers in Chennai, which was Adyar Cancer Institute. And I have also trained for a bit at Tata Memorial Hospital in Bombay, again, one of India's top cancer institutes, which caters to a majority of the population. And I have trained in breast oncology. Happy Women's Day, everyone. So I was asked to, talk to you all about breast cancer awareness. And breast cancer awareness, it's been done to death. Like everyone talks about screening, everyone talks about risk factors, and almost every Women's Day or whenever October, that is Breast Cancer Awareness Month, we talk about all this. But I have decided to tackle another aspect of breast cancer awareness today, which is management. And I'll come to why I've chosen this topic specifically. So as you can see, breast cancer is the commonest cancer today worldwide. Earlier in low middle income countries like India, cervical cancer was the commonest cancer. However, the incidence of breast cancer has been rising rapidly over the years, and then it overtook cervical cancer and was the leading cancer amongst women, whereas lung cancer was the leading cancer amongst men. But today, if you see last year in 2021, the total incidence of breast cancer in both men and women, it overtook and it's become the most common cancer in the whole world today. And that's the pace with which it's rising. So the statistics say that at least 1 in 8 women can be expected to be diagnosed with breast cancer or to develop breast cancer at some point in their lifetime. Moreover, rather than being the most common cancer, it is also the most common cause of mortality due to cancer. These are statistics. These pie charts is what I've borrowed from the Globocan website. So these statistics are quite accurate. And if you can see the first pie charts, they show the incidence and mortality of breast cancer in both sexes, followed by the statistics in males and females. And you can see that breast cancer is the leading cancer worldwide. Also, there are a lot of inequalities that are associated with the care as well as survival statistics associated with this disease between the lower income and the high income countries. And there's a similar situation that you can see in the urban versus the rural areas as well. So, by this, I mean that the survival associated with the disease is much superior in the higher income countries and the urban areas versus the lower income countries and the rural areas. Now, another statistic that I'd like to bring to your attention is that today 50 to 60% of the cases of breast cancer that are diagnosed amongst women in India, they present in advanced stages of the disease, whereas in comparison to the West, where the locally advanced or the advanced cancers are less than 10% in incidence. The reasons for this are many. Lack of awareness. There is no nationalized screening program that we have in the country. Apart from that, the various social taboos and fear that is prevalent in society. Fear of the C word, cancer, fear of being, of having to go see a doctor, having to show her breast, fear of having to undergo the various treatments that are associated with cancer. And as you can see, the treatments that are associated with cancer, be it chemotherapy, be it surgery, it has been villainized and demonized to a large extent in various be it in the media or articles, and people talk of it in society with a lot of fright, which is why rather than talk about the most oft discussed topics such as screening, risk factors, and self breast examination, which is of course very, very important for early detection of the disease, I thought I could maybe take this opportunity that SEMS Welfare Association has provided me to talk to you all a bit and hopefully enlighten you about what goes into managing breast cancer. How do you treat it? How do you diagnose the disease? Because I believe at the end of the day that knowledge is power. And when you have the knowledge, you are empowered to make decisions for yourselves and take care of your own health, and that would also drive fear away to a large extent. So when we talk about management of breast cancer, I'd like to discuss it under two headings. First, of course, is diagnosis and staging, and then followed by treatment. I'll move on to the treatment aspect. So when a patient or a woman first walks into my breast clinic with whatever complaint, be it a breast lump, be it a nipple discharge, be it some kind of discoloration, the first thing that we do, of course, is to take a detailed history and to do a detailed clinical examination. But after that, I would advise her a few tests. The first thing that I would like to do is a detailed breast imaging. Typically, a woman over the age of 40, I would advise her a bilateral mammography. Now, what is a mammogram? If you can see in the first picture, the woman with her breast compressed between the two plates, that's exactly what a mammogram is. So the breast is placed between two plates. The above one is a plastic plate. It is made to compress the breast slowly, and then you have x-rays that are passed through this plate, capturing the image of the breast on a camera for us. So this way, it enables us to see any abnormalities that may be present in the breast. For example, if there is a lump, I can see where the lump is situated. I can see the size of the lump, the extent of the lump. Is it only present in that area? Are there multiple lumps? Is it scattered all over? And in case it is it accompanied by other abnormal features, like are there microcalcifications? It also gives me information about the density of the breast. And a mammogram typically takes less than 5 minutes. It's a minute or two for the positioning, and the actual test is only 30 seconds or so. So a lot of women who are afraid of going and getting a mammogram done because of the pain associated with it, I implore you to not think about the pain, because the compression that is involved is hardly for a few seconds, but to go and get your mammogram done, because the benefits of early detection of the disease far it supersedes the pain or the discomfort that one feels while undergoing a mammogram. Now, the mammogram that I'm talking about is a 2D mammogram, two-dimensional mammogram. It is taken in two views. So one is the view that you can see. We call it the craniocaudal view, right? And then the other view is where this whole apparatus is turned diagonally. We compress the breast diagonally, and that's called the mediolateral view. So that is your typical mammogram. And it is essential, especially if you're going for a screening mammogram, that the mammography machine be a digital mammogram. That gives greater clarity and helps us visualize any suspicious or tiny non-palpable lesions more clearly. Now, the other development in technology that is available to us is something called a tomosynthesis. So what happens in a tomosynthesis? It's nothing but a three-dimensional mammogram or a 3D mammography. So what happens is the process is the same. You have X-rays that is passed through the plates, but you also have a tube that moves in an arc like this over the breast when the woman is being imaged. So because it's moving in an arc, it literally captures images of the breast in various sections. So when I get the images of a tomosynthesis, I can literally see section-wise what's happening in the breast. So this is an added advantage, especially in denser breasts or when we want to ensure of a surgical planning of cancer, when we want to ensure that we've taken most of the tumor out. And the mammogram is more often than not, it is accompanied by an ultrasonography examination, wherein that gives us, that helps us corroborate the findings that we see on the mammogram. And it also gives us additional information about the lump. For example, what kind of a lump is it? Is this a solid lump? Does it look, is it suspicious for malignancy, or is it a cystic lump? Could it be a fibroadenoma? It helps us with the location. It helps us guide. So the image down, that is how an ultrasound is done. So when the ultrasound is being done, you localize the lesion, and that helps you guide the needle when you want to do a biopsy or some other intervention. And then, of course, when the woman comes back to me, patient comes back to me, she's got a mammogram, she's got an ultrasound, but even this is not adequate for me to make my decision, then I may ask her to get an additional imaging done, namely the MRI or the magnetic resonance imaging. Now, these three, so why do we have so many investigations available? Because every investigation has a specific sensitivity, specific, specificity. They all have their strengths and weaknesses. So we utilize each and every one of these investigations for their strengths, put together the information, and that helps us with the diagnosis, and then, of course, for surgical planning if required. Now, once we have visualized where the lesion is, what's happening, the next thing we need to do is a sampling. You need to find out what exactly is that lump. Okay, it looks suspicious for a malignancy, or maybe it looks like it could be a benign lesion. But how are you going to confirm it? So for this, we do something that is called a biopsy. A biopsy is basically sampling the tumor. It can be done in any manner. It can be done using a syringe. That's when we call it a fine needle aspiration cytology, FNAC. It can be done using a core biopsy needle or a gun, that is a second image, or we could just take the patient up for surgery and do what is known as an excision biopsy. But the last option is very rarely done. It's always better, especially in the breast, to have a diagnosis before you go in for formal surgery. Unless, of course, the biopsy report itself is not very conclusive. So a lot of patients, at least in the setup that I practice in India, so India is a lower and middle income country, it's an LMIC. So the kind of setup that I practice in, a lot of patients, they get their initial testing is done somewhere in the periphery, the smaller clinics by a gynecologist. And the general trend here is to get something called an FNAC done. Okay, so FNAC is the first picture where you use a syringe. So it's a very thin needle that goes into the tumor. They aspirate material and send it for testing. But what I'd like you all to understand is that is not the ideal, because when you use your syringe, and especially for the breast, if you're talking about organs like the thyroid, it's a different thing completely. But for the breast, a breast lump, we'd like more information. So we would always advise the patient to undergo a core needle biopsy, which uses a much thicker needle. So when we talk about a thicker needle, we get so much more information. Because we get so much more material. Now, what am I looking for in a biopsy? I want to look at what is the lesion. Is it a cancer? Is it not? If it is a cancer, what kind of cancer it is? Is it a ductal cancer? Is it a lobular cancer? I want to know the grade. What is the grade of the tumor? And other similar pathological characteristics. All this is told to us by just that biopsy specimen. And now, apart from that, I also ask additionally for something called as receptor study, right? So I ask for the estrogen receptor, progesterone receptor, HER2 receptor, and the Ki67, which is a proliferation index. Now, what are these markers? Okay, so these are the markers that help me with the information as to how is this tumor going to behave. So we do this especially for cancers, only for cancers actually. And this is going to tell me, okay, now she has a cancer. Is it an aggressive cancer? Is it an indolent cancer? Is it rich in this particular protein called HER2? So this information, these markers, they tell me how your tumor is going to behave. So with that information, I can personalize or tailor the treatment as per the individual according to the disease that he or she may have. So now we've seen the breast, we've seen the lesions, we've seen the images. Now we've taken a biopsy. What's the next step? We need to ensure that the disease is restricted to the breast and it's not spread out. So what do? We do something called a metastatic workup. So a metastasis is when the cancer spreads outside the organ of origin, right? And that is something that we are not keen on. So for the metastatic workup, typically we need to check the various organs. So we do a chest X-ray to check the lungs. We do an ultrasound abdomen pelvis to check the entire abdominal area. We do a bone scan, and sometimes the X-ray chest is not adequate, so it's preferable to do a CT scan of the thorax, the abdomen, and the pelvis, and then a bone scan. But especially in private setups and in an economy like Asia, where most of our healthcare expenditure comes out of our own pockets, patients don't like getting 2 or 3 tests done individually. They would rather get just one test done, which is why a lot of us, especially in the private setups, we advise our patients to get a PET scan done. So I've put some images of PET CT below. So that's exactly what it does. It's an FDG PET CT. So it's basically fluorodeoxyglucose dye, which is injected. And, any lesion, anything in the body which has a high metabolic activity will take up this dye and it will shine like the sun, as you can see in the images. So that will tell us if there is anything abnormal and has it spread elsewhere, like to the bone or to the liver or to the lungs, etc. And then we put all this information together, and what we do is something called staging, where we stage the disease. Right. So this is what a lot of you may be familiar with. The first thing that patients come and ask me after the very first consult, when I've seen the patient, doctor, what is the stage, of this cancer? So there are 4 stages. Stage 0, there is stage 0, of course, which is very, very early non-invasive cancer. Then you have stage 1, 2, 3, and 4. And based on, the tumor characteristics, the nodal characteristics, so based on your clinical exam, your imaging, and your biopsy and the metastatic workup, we stage the patient. And based on the stage, the treatment regimen is tailored. So now we've completed the diagnosis process. And why have I spent so much time in talking to you all about the diagnosis? That's because a lot of us, we are very unaware of these options. So when we go to the doctor's clinic and the doctor tells us, okay, you have to do a mammogram, and then after that you have to do an MRI, very often, we are met with suspicion or doubt as to, I've just done a mammogram, or I've gotten an ultrasound done as well. Now, why is she asking me to do an MRI? Similarly with the biopsy. So this was an attempt on my part to tell you all why we do certain investigations. And I think that knowledge is very important to empower our patients. Moving on, I go to the treatment of breast cancer. Now, the treatment of breast cancer is a long, drawn out process. But you must realize and you must understand that if the tumor is diagnosed in the early stages of the disease, then we are able to offer a cure rate of almost 99%. We can cure the patient of cancer. And of course, we do keep them on very close follow up after that. So the three basic modalities, okay, of treatment of breast cancer include surgery, chemotherapy, radiation, and then of course you have other modalities like hormonal therapy, which is basically given in patients who are hormone receptor positive. So we give them these tablets for a period of 5 years or 7 years, which will block production of the hormone and therefore keep the breast cancer at bay. So I'm going to talk about now the first option, surgery. And before I move on to that, I would like to tell you all that treatment of breast cancer is not only surgery or only radiation or just chemotherapy. It may be a combination of all three. It may be only surgery, or it may be just surgery and radiation. It can be a combination of anything. But surgery is required almost 100% of the time, except of course when the disease is very advanced and has spread to other organs as well. So, these are just the various modalities of surgery that are mentioned here. You have mastectomy, you have breast conservation, plus or minus reconstruction. So, in the next slide where I've shown you all the pictures of patients who've been treated, the first picture on the extreme left-hand side, if you see, is what used to be done in the past. 4-5 decades ago, radical mastectomy was what is common because the belief was that, the more you remove, the better control of breast cancer. But since then, we've come a long way. We've now begun to understand the biology of breast cancer a little bit, and we do know that radical treatments does not mean better cure. Since then, it has been proven that even a breast conservation is as effective as a modified radical mastectomy, as long as you have removed the tumor completely and not left anything behind. So gone are the days when having a tumor in the breast or being detected with cancer would mean losing your breast. No. Today we have options of breast conservation where we can make your breast look the way it was before. We can make it match the opposite breast. In fact, we sometimes, when you do a breast conservation, the breast automatically gets a lift and it looks so much younger. So many a time we'll have to operate the opposite, the normal breast, so that it matches the operated breast. And then even if a woman is having to undergo a mastectomy, we can offer her breast reconstruction after that using the patient's own tissue. So we call that autologous breast reconstruction. We can also do things like skin sparing mastectomy, nipple sparing mastectomy, where the nipple is also saved. And of course, the breast tissue is removed and then reconstruction is done by, using an implant. But of course, it is essential. I would not generalize these options. It is very essential that we look at the patient whom we are treating, we look at his or her disease characteristics, and then, offer them treatment options accordingly. So a detailed discussion with your breast oncoplastic surgeon is required. Now, this next option, chemotherapy, this is one of the options which has been villainized so much in society, and that's because of all the side effects that are associated with it. People are they don't mind going under the knife or undergoing surgery as long as it's being done under general anesthesia, but they are frightened of chemotherapy. And a lot of people are unaware of what chemotherapy is. And which adds to the fear. So let me tell you, chemotherapy is just like any other medication, an IV medication that you would take. It is given intravenously, and it's basically toxic medication which is toxic to rapidly dividing cells, that is cancer cells, right? And obviously, because it is Cancer cells are proliferating with that, with that intensity, which is why these toxic medications act on it. But there are other cells in the body as well, like those of the ovaries and the hair follicles are also multiplying rapidly, which is why the chemotherapy drugs act on those cells as well and give rise to side effects such as, your menstrual cycles may stop, patients start losing hair. But let me tell you that these side effects are not permanent, they're very temporary. The moment chemotherapy is stopped, a patient's hair might, grow back again. And of course, ovarian preservation is a little bit more complicated. So if a woman who, is of childbearing age and has not completed her family and she's suffering from cancer, what we do is, along with chemotherapy, we give something to block her ovaries so that the chemotherapy drug does not affect the ovaries. But the treatment is really personalized to what the patient has, the behavior of the tumor, etc. So accordingly, we can decide whether to give the chemotherapy first, that is prior to surgery. So chemotherapy followed by surgery plus or minus radiation, or we can decide to operate first and then go ahead with chemotherapy. It really depends on the size of the lump, the breast tumor ratio. So the size of the breast in relation to the size of the tumor and the character of the tumor. Is it an aggressive subtype? Is it more indolent? And then, of course, here you have the final option, that is radiation therapy. Now, unfortunately, I don't know how it is in the rest of Asia, but in India, unfortunately, in common parlance, radiation is referred to as current therapy. So if I were to talk to, say, a patient and to counsel them for radiation therapy, current therapy is what is very, very commonly used. So what patients are told is, okay, now you've undergone surgery, you've received your chemotherapy, then now the next is current therapy. So a lot of patients are frightened because they think we're going to electrocute them. So let me tell you, we don't electrocute people. Radiation is not equal to, passing current through the tumor. Radiation is just that. It's just like X-rays, or, it's like you getting a chest X-ray done. It's as simple as that. So, for example, if a woman is suffering from breast cancer, she's been treated. So we make her lie down on a cot, and she is positioned. The organ that has to be radiated is positioned in such a way that it is stable. A mold is made out of it. And then the radiation beam is focused accordingly. The planning of how the radiation must be given, how much is given, to what depth should it reach, what is the field that it has to cover, all that is done on the computer, right? And then after that, the radiation is delivered, and the actual radiation therapy is hardly a few minutes. So a lot more time is taken to actually position the patient on the cot, and then radiation is delivered, which is only a few minutes. And the side effects that are associated with radiation, at least on the skin, is not much, is not equivalent to what a patient may undergo while undergoing chemotherapy. Yes, there is some amount of skin hyperpigmentation. That area may look like the patient has maybe, gotten a skin tan or a suntan. There may be some amount of skin peeling, but it's very relative. So the complications may be higher in someone who's a diabetic, or may be higher in slightly older individuals, or in someone who is very obese. But it cannot be generalized. And we also have today, science, at least we have protocols set up. So we do know that in case these, complications were to occur, how it should be managed. And we also inform the patients of the various precautions that they need to take during the treatment. So like I said earlier, treatment of breast cancer is not restricted to just one modality. Very rarely it may involve only surgery, maybe if it was a very early type of non-invasive cancer. More often than not, the treatment of breast cancer requires a detailed multidisciplinary approach. It requires a close interaction between the surgical oncologist, the medical, and the radiation oncology teams primarily. We require the help of a radiologist, a pathologist, a plastic surgeon, and the other members of the team are equally important, and they include breast nurse, genetic counselor, physiotherapist, fertility specialist, psycho-oncologists, etc. So I think gone are the days when we used to treat patients so radically and literally, in the earlier days, more than 100 years ago, when breast cancer was being treated, the approach was very radical. They would remove the breast, they would remove all the nodes in the underarms, in the neck, in the internal mammary node area. They would remove the underlying muscles. To one point, there is one very shocking report that I've read where they went ahead and even removed that patient's arm, because what they thought was the more you remove, the better the control. But thankfully, thanks to science, thanks to researchers and the time and their dedication, we now know that that is not true. So I'm very happy to say that we now belong to an era wherein we can provide patients treatment for the cancer in a wholesome manner with empathy, and we personalize the treatment to not just the cancer but also the patient and his or her lifestyle. Thank you so much. That is my email below. Please feel free to, you want to ask any questions, you want to take appointments, you have any queries, feel free to drop me a mail. Yeah. Thank you. Thank you so much. Okay. I'll be happy to take any questions if you all have some for me.
Thank you so much for an eye-opening session. I'm sure all the participants must have learned something from you. A doubt from my side, it's generally said that after menopause, the risk of cancer is, more. So why is it so? Why is cancer related to periods, breast cancer related to periods?
Okay. So, the why breast cancer is related to periods is because now we know from research that one of the major risk factors for breast cancer is increased level of the hormone estrogen, right? So, estrogen is present in each and every woman. So, the biggest risk factor for getting breast cancer is the fact that we're women and the fact that we're, growing old every year, right? With every year we are increasing in age, correct? So that is the other risk factor, and this is something that we can do nothing about. So when it comes to estrogen, now you're very right. They say that this, when the amount of estrogen exposure is increased, that will increase a woman's risk for getting cancer. Be it, say for example, somebody who gets their periods very early. So maybe somebody who starts menstruating at the age of 10, and then she stops menstruating at the age of 60. So, she has been exposed to estrogen hormone circulation for a cumulative period of 50 years versus someone who has maybe gotten her periods at the age of 14 and then her has attained menopause at the age of 50, right? So the period of exposure is so much less. So obviously the first patient, the risk would be much higher. Similarly, someone who is nulliparous, has not had children, or who has not engaged in breastfeeding, they are also prone to a higher risk, because this process of pregnancy and breastfeeding, it cuts your supply of estrogen. So you're not exposed to estrogen in that period of time. But having said that, I must tell you that we see patients routinely who've had 2 kids, 3 children. I've seen patients with 4, 5 children also from the villages who have gotten breast cancer. But those patients are much older. So, like I said, the biggest risk factor for getting breast cancer is being a woman, of course, increasing age. And then, of course, we need to be very aware. We need to do self breast examination. We need to follow screening protocols in order to in order to detect the cancer at an early stage and treat it. Now, why are women more prone to getting breast cancer once they attain menopause? Okay. So once a woman attains menopause, her ovaries stop working. So there's no estrogen. So how does she develop breast cancer? That's because estrogen is being produced in the periphery, in her fat. So if a woman who is postmenopausal but is overweight or obese, has a lot of fat deposits in the body, she is at a higher risk, because there is estrogen which is being produced in the fat. There is a hormone called aromatase. So this aromatase is increasing the production of estrogen, therefore increasing a postmenopausal woman's risk for getting breast cancer. Secondly, the other thing about adipose tissue of fat is that excess fat puts your body at a state of chronic inflammation. So when an area is inflamed, say you hurt your hand or something, that area, there is swelling, there is redness, there is pain. So imagine your whole body is put in that state of chronic inflammation. That stress induces genetic mutations, and induces cellular alterations, which gives rise to which may cause cancer to develop.
Okay. Someone asked that if someone has PCOD, is she more prone to cancer, breast cancer, or
So
cancer?
someone, a lot of PCOD is very, very common, PCOS, right? That does not increase your risk for developing breast cancer. There's no evidence to say so. However, women who are on PCOS and those who require hormonal medications, who are put on hormonal medications, so they typically started on oral contraceptive pills or other hormonal medications. If it's given for a prolonged period of time, then definitely they are at an increased risk for developing cancer. So the best way to get PCOS under control is weight control. Unfortunately, it's a very vicious cycle. So weight increases, PCOS worsens, and because PCOS worsens, it's very difficult to control weight or lose weight. So it's a vicious cycle, but it can be done. So if you manage to maintain your weight and reduce PCOS, you can also stop your intake of oral contraceptive pills or medication. But of course, I would recommend that you listen to your doctor, have this dialogue, have this discussion with your doctor, and then decide whether to stop the medication or not. I would only advise you all that you don't take any sort of hormonal supplements, be it for PCOD, be it for contraception over a prolonged period like 4 years, 5 years. That will definitely increase your risk.
Okay. So, all right then, let's give a big hand for Manjula ma'am for joining us today and
Thank
enlightening
you.
us on breast cancer awareness. Thank you, ma'am, and thank you, everyone. That's it for today. We appreciate you all for being here.